And I suppose, as they say in showbiz, follow that, because, Jonny, you've got a tough act to follow. Jonny Taitz from Sydney in Australia, originally from Cape Town. And I was just explaining to Jonny that my daughter moved out to Australia and she's having her first child in the hospital he works in. So we're doing a little bit of negotiating to make sure she gets that extra tea and toast in the morning. But, Jonny, thank you very much.
Well, good morning to everyone, and thanks very much for joining us at this session. My accent, as you can tell, is not classic Australian because of my birth and upbringing in Cape Town, South Africa, and I'm actually going to tell you about a journey that I undertook in the United States. So nothing really about the Australian health system except for the context. So I'm unashamedly going to do, during the course of the talk, an advertorial for the Harkness Fellowships, and there is a lunchtime session on that tomorrow, and I was very fortunate to be selected from Australia to spend a year at Harvard Medical School in Boston doing a Harkness Fellowship. And for me and my career, it was simply transformational, if there's such a word, but kind of my career is a before and after. And part of my presentation today is going to be a little bit about that trip and the kind of stuff that we did and the research that we undertook. Because if you get selected for a Harkness Fellowship, you have to undertake a broad research-based question. So I want to acknowledge the funding from the Commonwealth Fund and also my colleagues at Harvard Medical School and Partners Health System. For those of you that aren't familiar with the US or the Boston setup, Partners are what I call the big dog in town. They manage the very two large teaching hospitals in the adult world, which is Mass General and the Brigham, which, as you all know, has been very busy the last few days. I took my wife and my two young kids on this experience, and we made a lot of very good friends. And part of that was actually being able to renew those acquaintances and research connections. And so before coming here, I spent the last week in Boston. And I'm a marathon runner. Those who know me, I've run the Boston 4 times, and I would have run on Monday, except I was coming to the conference. But my best friend ran, and that's her in the black, just over there, about 50 meters away from the bomb blast. So when people say our thoughts and prayers are with the folks in Boston, from me and my family, that really is true. But that is a very close call, and I would have run with her. So very lucky to be safe, and obviously my thoughts are with all my colleagues in Boston. So as I mentioned, I was based at Harvard Medical School. I was very lucky to have a mentor in Tom Lee, who, besides being the deputy editor of the New England Journal of Medicine, is the CEO of the Peachy Health System within Partners, and an incredibly well-known figure in Boston, and allowed me to meet all sorts of folks. The Boston community was incredibly friendly and welcoming, and if people didn't respond to my email, I simply CC'd Tom on the second one, and it was amazing how responsive people were in that case. And also with Tom Sequest at the Harvard Medical School. So prior to going, I want to talk a little bit about what I call the physician's paradox, and I'm sure this will resonate with most of you. I'm a paediatrician by training. I'm still clinically active. I've worked in England, South Africa, spent time in the States as well. And everywhere I go, I meet doctors that are hardworking and are interested and are deeply committed to their patients on an individual level. But so many of my colleagues are disillusioned, disgruntled, unhappy with the system. And I'm fascinated about why there's that paradox, what I call the physician paradox. Deep intrinsic commitment to patients individually, but a deep mistrust of the system. And so it was with that question in mind that we embarked to the US. So there's no doubt that physicians over the last 20 years have largely abrogated the responsibility of managing the health system to others around the health system, and then have kind of said, well, we weren't consulted and our voice isn't heard when it comes to managing the health system. And there are lots and lots of barriers to physician engagement, but it's very clear that we can no longer, as physicians, delegate this to others within the health system. And intrinsically, I believe that physicians that are engaged are much more likely to care about patient outcomes. Because I believe that physicians are very smart and talented people, and we could have all been investment bankers. The reason that most physicians didn't become investment bankers was simply because we care about patients. And that's one of the big dividing differences, but yet why are we so estranged from the health systems within which we work? So we decided to do a study where we looked at what we thought were 10 of the high-performing hospitals in the US, and we wanted to ask a few simple questions. How do you engage your physicians in quality and safety? What are the drivers and barriers to that engagement? And are you aware, and can you tell us what the costs of engaging your physicians in quality and safety are? So this was a qualitative study, and we decided to use a convenience sample. In America, unlike Australia, for example, it's fiercely competitive because of the variation in the system. and people will complain about the number of different organizations that measure hospital performance. But two of the big ones are the US News and World Report, which comes out in about May, and also the Leapfrog study. And so we used that as a starting point to try and get engagement with the different hospitals. Even though I'm a paediatrician and I worked in a big children's hospital, we decided to make it a mix of adult and pediatric hospitals. Our study was approved appropriately by the ethics group within Partners. And then we set up a semi-structured interview, and we piloted that interview and made some changes once we'd done the first series of interviews. So I was very lucky that American Airlines took me to all these hospitals safely. And I thought just for a moment I might just run through some of the key points of these hospitals, because these are all very well-known hospitals, and particularly those that aren't familiar with the US system might be interested in learning. So for example, Partners, and I mentioned Partners is about 16 group of hospitals, about 6,000 physicians, about $6 billion in turnover, so on a massive scale compared to where I come from. And really the Mass General and Brigham are the flagship academic hospitals of the Harvard Medical School. And I often said to Tom that perhaps research may be more important than patient care, and it was an issue that we often debated. The Children's Hospital at Boston is co-located next to the medical school, and I was particularly impressed with the way that they tied academic promotion to working quality and safety. I hadn't seen that done anywhere before or since. Cincinnati Children's Hospital, I think, is the world's premier children's hospital when it comes to quality and safety. And Uma Kodagal and Steve Muthing are incredibly passionate and inspiring healthcare leaders, and I would encourage anyone to go to Cincinnati in the summer, unlike I did in the winter, because it's a wonderful place to learn. And their journey started about a decade ago when they believed incorrectly that they were in the top quarter of performance for cystic fibrosis outcomes. And when they looked at their data, they actually found out they were in the bottom quartile. And they wrote to all their patients saying, unfortunately, we've done our calculations, we're in the bottom quartile, we'd like you to come with us on a journey to get to the top 10%. And I'll show you some pictures. When you walk into Cincinnati Children's Hospital, the whole foyer is covered with quality awards. I hope you're under no impression whatsoever that this is one of the world's top performing hospitals for quality and safety. They breathe it, they live it, they talk it, they eat it. It's a very inspiring place. The Cleveland Clinic you saw yesterday in I think it was the first session, that wonderful advert. And the Cleveland Clinic is an amazing place. Cleveland is unfortunately a depressed city, not far behind Detroit. Again, I happened to be there in January and it was pretty chilly, because I'm from the southern hemisphere, and you'll see some slides. Basically, you either work for the Cleveland Clinic or you're pretty much unemployed. I think it has about 43,000 staff. And a week before we went to Cleveland, we did a review at the Harvard Business School. And their CEO, Toby Cosgrove, is an incredibly inspiring individual. And he said, health starts with staff first. He said to his staff, if you're a smoker, you have 3 months to stop smoking or stop working at the Cleveland Clinic. Everyone wears a pedometer and is expected to walk 10,000 steps a day. And he banned the sale of Coca-Cola and fatty foods and candy and lolly, sweets, whatever you want to call it, from the shops. So the first day I arrived at the Cleveland Clinic, I went to the first shop and I said I'd have a large Coke and a side order of fries. Sorry, sir, we don't serve it. And I couldn't find it anywhere. So I was really impressed with the commitment to health. Geisinger Health System, I have never seen rural healthcare done on such a large scale and so effectively. It's an 850-bed hospital, literally in Danville, Pennsylvania, which has 2 shops and a small country road. And the nearest place is Hershey, which is world famous for those awful chocolates that they make. The Mayo Clinic, in my opinion, is one of the most impressive places in the world in terms of culture. And we always say culture eats strategy for lunch. I'll just tell you 2 quick stories about the Mayo Clinic. Everyone at the Mayo, all the doctors carry 2 pages. The one page is to say, pick up the kids after school, you forgot the lunch, whatever. The second pager is where a colleague wants you to consult on a patient. And their expectation at the Mayo is, unless you're busy with the resuscitation, you answer that pager and respond immediately. We then went off for lunch, and we went to a different part of the hospital. And if you have a lunchtime meeting, there's a cafeteria which gives all the people meeting a free lunch, because they want you to focus on the contents of the meeting and not worry when you're going to get a moment to get a sandwich on your busy day. And I thought just those 2 things, besides the fact that you see data displayed everywhere in the Mayo Clinic, is very impressive. Intermountain Healthcare, you'll all be familiar with. Brent James spent a wonderful week in Salt Lake City, and they really understand that quality drives down costs. And it's probably one of the world's premier sites for teaching. Mass General Hospital in Boston recognizes that incentive payments may work. And so they will pay their physicians sometimes very small amounts of money to fill in a questionnaire, to wash their hands, to fill in the operative notes. And it's very interesting to compare that to other sites. And finally, Virginia Mason, when I got to see Gary Kaplan, who I think is Speaking today as well, they'd just been named, Virginia Mason had just been named by the Leapfrog study as the top hospital of the decade. And there's over 5,000 or 6,000 hospitals. And I said to Gary, how does that make you feel? And in his true inspiring words, Gary said to me, that's great, I'm very happy for the team, but I'm restless to do more. And Virginia Mason, for me, they've employed a compact with their physicians, and I'll talk a little bit about that. But for me, that was the best example of how you engage physicians using a compact. This doesn't project very well, but simply the size of these places. So, for example, the Partners Healthcare system has 2,500 beds, the Brigham 800, Mass General just under 1,000, the Mayo Clinic has 2,000 beds, Cleveland Clinic 1,160. So very large, multi-site facilities. Intermountain in Salt Lake City has 2,500 beds. All of these were teaching hospitals. So just some pictures. Again, I'm not sure how well it projects, but I got to Mayo Clinic, and again, I'm from Sydney and from Cape Town. We don't do snow. So when it was minus 20 degrees centigrade and snowing in December, that was a big shock to me. One of the things that was really impressive was wherever you went at the Mayo Clinic, public, patient, private areas, their dashboards were being displayed. And some of their data wasn't particularly good, but they were displaying it and owning it. And because medical tourism is such a big deal in the US, the hotel, the Kayla Grand, is co-located, and I've never seen so many wheelchairs in the foyer of a hotel. The Cleveland Clinic, only diet cold drinks being served. You cannot find a proper sugary drink anywhere in the hospital facility. And again, Cincinnati Children's Hospital, as you walk in, I couldn't even get a picture of all of them, just layers and layers of awards that they've won in their journey to improve pediatric safety and quality. And finally, Geisinger, this incredible hospital, literally in the middle of nowhere. Children's Hospital Boston, I'll just tell you a quick anecdote. Hopefully I'm not offending anyone at Children's Boston. But the whole year we'd had discussions about the methodology of the US News and World Report, and that it's methodologically unsound. Because for the previous 6 years, Children's Hospital Philadelphia had been voted #1 hospital for children's, and Children's Boston was #2. When I was there in May, Children's Hospital Boston, for the first time in 7 years, was voted the best children's hospital in the US. And despite all the methodological concerns raised by them, there was a banner across the whole of the Longwood Avenue celebrating that success. Intermountain Salt Lake City. If you haven't been to Salt Lake City, it's a fantastic place for skiing, and if you want to have more than one partner legally, this is really the place to go. But incredible, because you can walk from downtown, from Intermountain, you can walk to the ski fields in 20 minutes. So, that's a little bit of the advertorial. So we managed to do 42 interviews over the 6-month period, and it varied between 3 and 6 per site. They were all confidential and de-identified, and obviously complete consent was obtained. We transcribed them, and then we coded and analysed them, looked for differences, and sorted them through between the 3 of us. Just to give you a sense of who we interviewed, CEOs, chief medical officers, in America, vice presidents for quality and safety, a number of physicians, quality officers, and patient safety officers, to give us a kind of mix of different folks. And it was interesting asking them the same questions, their perspective on the issues. So a total of 46 staff in total. And the first thing I'll start with, and these are the words of some of the much more smarter people that I interviewed. We said, what do you understand by the concept of physician engagement? And I'll just go through 3 or 4 of some of the smarter comments. So, physician engagement is purposeful, constant commitment to organizational objectives around quality and safety. It's around physicians owning the most optimal way healthcare is delivered. And this one I like. You can't control variation without physician engagement and behavior. And it's getting physicians to think about processes and systems beyond the individual patients in which they care for. During the year, because of the Commonwealth Fund, we were very lucky to spend time in DC, and Kim Beasley's the ambassador from Australia, and John Laws actually was in the Million Man March with Martin Luther King. So amazing to spend some time on Capitol Hill with these folks. That's my kids having a fun time in San Francisco. So as a result of all these interviews and all the coding, what do we come up with? We come up with what we call a 6-point engagement framework. And I'm going to spend the rest of the talk, except for the last few minutes, just going through each of those concepts and spelling them out in more detail so people can follow along. The first thing you need is engaged leadership, and I think that's a hallmark of a high-performing system, because all the high-performing systems we went to all have engaged leadership. Once you have engaged leadership, you need to start developing a physician compact. And I'm going to talk to you a little bit in more detail about a compact, because it's not a contract. It's got nothing to do with your pay or your remuneration, because we spoke about it a bit earlier. You then have the ability to start talking about compensation for time and for money, and to start aligning your financial incentives to things that are important for the organization and for patients. And then how do you use data in a meaningful way, and how do you give physicians, because it's no point just giving a doctor some data on how they're performing and leaving it there. You have to give physicians an enabler, a way to improve their performance. And finally, this whole notion of academic promotion, how does that fit in terms of the framework? And I recognize that that's not an issue for everyone, but particularly people working at big tertiary or quaternary medical centers, academic promotion is an important reason why they work there. So let's have a look at that in turn. So just to look at the framework in a different way, a hospital realizes there's a problem with the engagement of their physicians. There's engaged leadership. You have the physician compact, which allows you to have the conversation around compensation, incentives, and data. And then you get your physicians more engaged, and you use academic promotion as a further lever. So let's just talk a little bit about engaged leadership. So a very common theme that came through was that you need leaders that understand physicians, the way they work, and are trusted by them. It's what I call street credibility. One of the big reasons there's a gulf between managers and physicians is that the physicians suspect the managers have never done the hard yards in the ER, or done the hard yards at 2 o'clock in the morning in the ICU. And you need leaders who've done that experience so that they can relate to the issues that physicians face. And this came through in about 70% of interviews. You need physicians to buy into quality and safety and develop a culture which has an institutional mandate for safety. And you need to align physicians and the organization with quality as a shared goal. And this concept of alignment came through very strongly as well. I want to spend a few moments talking about the physician compact, because this is a light bulb moment for me. So I'm going to set the scene. It's January. Boston's just had their second biggest blizzard, I think, in 10 years. I've got a meeting at MIT with a guy called Jack Silverson, the kind of godfather of the compact. And I get there, finally, in the snow, and he says to me, take your shoes off, which I do. And this is the best 4 hours I've ever had with my shoes off. So what we did was we then went and looked through the different issues about the compact. Now, physicians that are older than me, and my generation as well, when I finished my training in the early 90s, were told that when you finished medical school and you started working, you were going to be given 3 things. Autonomy to do pretty much as you want, protection from the system, and entitlement to remuneration, hours, and patients. Unfortunately, that system has long gone. And one of the big reasons that physicians find themselves at a loss at the moment is that they're still hankering and mourning for the old times when there was autonomy, protection, and entitlement. Nowadays, when you get to work in a health system, from the intern to the most senior professor, it's about teamwork, it's about multidisciplinary care, it's about outcomes, it's about measurement. None of the old stuff. And that's the reason doctors are so disillusioned, because what they expected and the way they're trained, the reality doesn't match that at all. So what a compact is, it's actually a conversation. It's not an end document. It's a conversation to have between the physicians, the surgeons, and the administration. What is important for each side? Because in most facilities I've been to, no one has ever even started having that conversation. So you have your managers over here looking at their priorities, which are largely around access and finances, and you have your clinicians and physicians on the other side, largely worried with patient care, and the two of them aren't talking. They aren't talking about what's important to each side. So in this document, you outline, and Virginia Mason took 12 months to work through this document, and every month they review a component to make sure both sides are sticking to it. So, for example, in most hospitals, you'd have a senior staff council and you'd have a CEO or a chief operations officer. And really, these are the two groups that need to work through this conversation. What does the institution expect from its physicians? Ward rounds before 10 a.m., outpatients seen on time, training and supervision of junior medical staff, for example. What do the physicians expect to provide its physicians? Secretarial support amazingly comes through. Respect and time to do the stuff that's important for me as well. A desk, a car parking space. Whatever those issues are, no one's talking about them, and that's the importance of a compact. But it requires honest dialogue between both parties, and it bridges the gap, as I said, between what physicians thought they were getting at the end of this medical school and residency deal and what's actually the reality on the ground. It came through in about 15% of interviews, and it talks about both tangible and intangible rewards. Again, as I mentioned, Gary Kaplan and his team at Virginia Mason review one component of the compact every month to make sure that both sides are adhering to it. And if there's one thing that I think came through from this whole physician engagement was around this importance for the conversation. Because I think physicians are now in the time and place and are ready to start having this conversation to focus on patients. On my return, I'll just give you a little anecdote. I spent some time up at the Gold Coast District Hospital just in Queensland. And we actually did a 2-day seminar with their new CEO. And I was amazed at about how ready and how willing and excited the senior clinicians in the room were to start having this conversation about what does quality mean at Gold Coast Health and what does a compact mean between the chief executive and the physician group. And in every organisation, you have your leaders who are the leaders on the chart, and you have your real leaders. And one of the real leaders, who was one of the surgeons, but clearly a very, very well-respected member of the group, got up and said, "Jonny, I'm paid more than enough by Gold Coast. Money's not an issue. This organisation doesn't respect my time. It doesn't allow me to. It doesn't give me time to do things that are important." And the CEO had never heard that. And so he knows that if he's going to start engaging his physicians, he needs to start looking at how he manages their time and making sure that they have enough time to do the things that are important. What about appropriate compensation? So again, I think this is something that's important for physicians, and it's mentioned in over half the interviews. One of the best comments I got during the year was someone said to me, "Jonny, you can't do quality at tea time and between cases." And if you just think about that comment and what it means, in the health system, we're all guilty of this. We find people that are incredibly successful, and we give them more and more and more work to do. And we expect them to do it at tea time and between their surgical cases. And hey, they become disillusioned, frustrated, and ineffective because they don't have the time to do it. So to be effective, and I think management needs to hear this, physicians need time, they need compensation, and they need acknowledgement. It's not an add-on. If you just do it as an add-on, it's going to lead to frustration and ultimately to poor outcomes. For salaried physicians, this actually means quarantining a percentage of their time. And in a fee-for-service environment, you need to consider paying physicians. At the Brigham, they pay their orthopedic surgeons, John, $20,000 a year just to sit in a committee, which I thought was quite amazing. But they said that's time off the floor from them. And if you're not going to compensate them, they're not going to come and participate. If you're paying physicians, though, you can expect outcomes. And so that's part of the bargain. What about financial incentives? Number 4 in the framework. This is a very controversial area, and if you look at the literature, it's equally divided. That says that financial incentives are a good lever and are effective for physician behaviour, and the other half of the literature says it doesn't make the slightest bit of difference, and the moment you remove the financial incentive, behaviour returns to the mean. I thought it was very interesting, of the 10 hospitals I went to, how differently different hospitals approach them. So at the Mass General, as I say, their physicians are sometimes on $400,000, $500,000, and will happily earn an extra $200 filling in a questionnaire. So their questionnaire response rate went from 3% to 73% when they offered that incentive. And they pay their physicians to wash their hands and to complete their surgical notes. The Mayo Clinic thought that's an incredible insult to the profession. That's part of the core business. As they said, you wouldn't expect the pilot, you're not going to pay the pilot of British Airways to get you to Heathrow safely. That's expected core business from the airline. So clearly within the United States, I thought it was very interesting to see this dichotomy of approach to incentives. And I think the jury's still out. But half the hospitals I surveyed had some sort of financial incentive in place. Now, it doesn't have to be financial. You know, in the English, Australian, New Zealand system, we say, financial incentives, that's American stuff. But in fact, all our targets, all our wait times, all our 4-hour rules, it's all tied to finances, fines, money, compensation in some way. So we're all engaged in that. It may not be directly. The problem with incentives, for the most part, is that there's a massive disconnect between physicians and those driving the quality agenda. So as a paediatrician, I didn't train for 14 years, and I don't get out of bed to beat the 4-hour rule. And I didn't get out of bed to wash my hands 95% of the time. But I sure as hell don't want any one of my patients to get a nosocomial infection. So I think the conversation is just framed incorrectly. And really what we have to do is start aligning incentives, if we're going to use them, on disease-specific outcomes that matter to patients and to their physicians, and take incentives away from broad-based access metrics. Unfortunately, for most politicians worldwide, access is easy to measure. And so there's certainly in Australia, there's an obsession, an unhealthy obsession with access data and metrics. And we don't focus enough on outcomes. So it's all very important to get patients measured in terms of waiting time for surgery, access to the emergency department, but what happens to them in hospital is kind of a big unknown, and we need to start focusing more on outcomes, because that's what's really important. What about number 5, data enablers? So this came through in about 2/3 of interviews. And I'll just tell you a little anecdote. When I've traveled the world and spoken to doctors, particularly paediatricians in my area, no one's ever said to me, Johnny, I think I'm below average as a paediatrician. I think I'm a B grade student. I think my peers are much better than me. No one's ever told me that. But statistically, we can't all be above average. The point of the matter is, up until now, really, we haven't the faintest idea how to measure performance of physicians. How do we do it? What are the outcomes that we're measuring? But I believe with electronic medical record coming into play, that this presents us with a window of opportunity. Now and the next decade is going to be all about using the EMR in an intelligent and a meaningful way to start measuring physician performance. I believe that if you said to physicians, I'm going to pay you $1,000 to reduce the number of CT scans in your patients with non-specific abdominal pain, you'll have very limited success with that. But if I took a group of paediatricians and I showed them who was doing the least number of CT scans for non-specific abdominal pain or had the best outcomes for asthma in terms of length of stay, by their nature, physicians are competitive. I know I would go find out who was the best performer and have a quiet chat with them and find out what they were doing differently to me. So it's not just about finances, but you have to do that in a protected environment. You can't. I don't believe releasing the data publicly will necessarily lead to the response that you want. So again, as I said in the beginning, you can't just give physicians data. You need to give them enablers. So I can't just say to physician A, you perform terribly in terms of cardiothoracic surgery or diabetes care or whatever it is. You need to say, your performance compared to your peers is way down here. These are some of the best performers. We're going to use registries, guidelines, whatever the case is to try and improve this. Let's have that conversation. And I believe physicians should also be responsible for measuring themselves. And this is an interesting concept. Instead of government, regulators, medical boards giving us a whole series of things that we have to measure, let the physicians go away and measure themselves. As long as those measures are meaningful, acceptable, and we're able to measure them, I think that's important. So for myself as a paediatrician, those measures would be very different to, say, a cardiologist. Door to balloon time, length of stay, side effects of medication in cardiac failure, I don't know. They can go away as a group, come back and tell us what's important, because then you engage them on measuring themselves and their colleagues. So data drives cultural change by identifying the best and the worst performers and learning from the best. Should data be published externally? And this was a very interesting question. Almost all the groups supported full internal transparency. About half of the group said you should publish physician-level data externally, and about a quarter were virulently against that. Of the hospitals that I saw, at least 5 were publishing in some form de-identified physician-level data. I believe at the moment that we really should be talking about a compromise option, which is full internal transparency amongst physician groups so that you can learn from the best. But I would just add a word of caution about publishing physician-level data externally, because I think unless that data is robust, the potential for damage to physicians, to their careers, to their egos, to the hospital, to the incomes is significant, and I think that would be a huge disincentive for academic promotion. Just very briefly, promotion traditionally has been linked to the amount of research, teaching and clinical work we do. But why don't we type promotion into quality and safety activities? This came through in about 15% of interviews. And Children's Boston, I think, is one of the best examples where all quality grants are peer-reviewed and QNS publications are regarded on research on a par with standard research. And it's now being regarded as an academic discipline. So just a sample of those hospitals. Not all of them are doing all of them, but engaged leadership, I think 100% of those hospitals showed engaged leadership. But just under half are using a physician compact in some form. They all recognise how to appropriately compensate physicians for time. Half are using incentives, and as I mentioned, a small number academic promotion, and about half are measuring data and publishing it. So what are the barriers to engagement? And this is no surprise, and it came to just a few weeks ago at the Gold Coast. Time would be the biggest one. The culture of physicians and autonomy. Their medical school training doesn't equip them for this sort of work. And interestingly, lack of quality support. And I'm sure you guys are all familiar with this because I've heard this a few times. Nothing will come of this. This is the 3rd time we're doing this guideline. This is the 4th working group I've done in this area, and nothing ever came of it, and I'm not going to waste my time. What about quality and safety programs? Very few of the senior leaders, I'm talking about VPs for quality and safety, chief quality officers, had done any formal training whatsoever in quality and safety. I found this amazing because I've never come across a cardiologist who's not board certified, who hasn't done their residency, who has annual reviews. But to be a leader in quality and safety, you can spend a weekend at the IHI. No disrespect to the IHI, of course, but a weekend's not a long time to immerse yourself in all the skills and discipline required for quality and safety. A number of the hospitals have training programs in quality and safety, but it's a dog's breakfast out there, differing levels, different duration. Some are mandatory for their juniors, but not their seniors. Of all the programs we saw, Brent James is one at Intermountain's the best. They've trained over 5,000 healthcare leaders, but that's a tip of the iceberg. So there's no doubt that I think we're at a stage in the quality and safety movement where we need to start talking about a core curriculum for leadership around quality and safety, so that all of us internationally are starting to use the same tools and talk the same language. But I think there's a way to go. What about measurement of physician engagement? Well, none of the hospitals were measuring any physician engagement directly, and none were aware of a validated tool to measure physician engagement. Some are using Press-Ganey, some are using culture of safety surveys, but all agreed, despite none of them doing it, they all agreed that this was a very worthwhile measure to measure physician engagement, if nothing else to give you a pulse of the organisation. What about the costs, just to finish off with? Again, very few of the hospitals that we surveyed had any idea of the costs. They recognised there were two costs. One is the setting up of the course, getting the faculty, which is actually a very small cost, the food, the catering. Getting people off the floor, away from their patients and their work, that's by far the bigger cost. Some hospitals had started doing some work, and one hospital estimated for every dollar they spent, they got a $4 to $5 return. One hospital, which was actually Virginia Mason, since they've started using the Compact and the Toyota system, have actually noticed a 50% reduction in their hospital liability premiums. And my final point, which for me was the best comment of the whole year, the cost of not engaging physicians in quality and safety is much higher than any cost associated with engagement. Thank you very much.
Jonny, thank you very much. Can I ask Sarah and Mark, first of all, any comments coming through on tweet,
Yeah,
Twitter?
lots of comments about the fact it's a conversation rather than a piece of paper. Everyone's very impressed about that. A question about the US system, if everything's incentivised, but we're led to believe that they're very broke financially.
So the first one is about the conversation.
Yeah, very.
So we're all familiar with, everyone does documents and they sit in the drawer somewhere and that's where they stay. The nice thing about the conversation with the Compact is it's actually the journey. And I think saying to your physicians, this is something important to management. We want to have a conversation about what's important to you, and we want to tell you what we think is important to us. And so I actually think the final document's less important than actually having that conversation, because for the first time, physicians will say, no one's ever asked me this stuff. No one's ever given me an opportunity to articulate that. And I see, as I say in my talk, I think that's the next big step for physicians that are struggling with this disillusioned, lack of entitlement in the system, is because no one's ever found out what's important to them, and what they thought they were getting into is actually very different. About incentives, my personal view is that I don't think financial incentives work for very long. Once you remove the incentive, people kind of go back to doing what they were doing before. I mean, the US health system spends a lot of money. It spends 17% of GDP, which is $2 trillion. My criticism of the US health system is I think for that spend, they don't necessarily get the good quality that they should get.
And I think some people were thinking that that's your professional responsibility anyway, some of the stuff you're...
Yeah, exactly. It's the story about the pilot. That BA or Qantas or American Airlines don't incentivize their pilots to get there on time because it might cause unnecessary risk-taking, and they certainly don't incentivize them for getting them there safely. Yeah. So the Mayo Clinic says washing your hands, filling in your operative notes, doing discharges is core business of a physician. The Mass General recognise it, but they incentivize their physicians to do those things. And it's interesting to think about. They believe that's effective at Mass General.
Jonny, you mentioned about measuring physician performance, but surely, the received wisdom is that, the high quality comes from good teamwork. So are you measuring the team, or are you measuring the individual physician? Well,
I think you need to start looking about outcomes. And I actually wouldn't measure... I would start by looking at patient outcomes as a proxy measure of how patients, of how doctors, physicians and teams are working to get those outcomes. So I think the next 5 years are all about, let's look at disease-specific outcomes. So, for example, in my profession, Cincinnati Children's has got 100 measures, 100 different conditions, ulcerative colitis, Crohn's disease, and have 7 or 8 measurable outcomes for each of those. So for an asthmatic, time off school, time off medication, missed sport. Those are the things that are really important in terms of the value proposition for patients. Not necessarily how long they waited for the surgery, even though access is important. It's overemphasized.
Thank you. Question here?
Mike Bergström, a paediatrician from Sweden. I want to have your reference of your study. I would like to I think it was very
It's actually
interesting.
published in the BMJ Quality and Safety last year, 2012.
So did you interview, how many junior doctors did you interview? Or was this senior people,
This was, yeah.
or are the ones that is to come?
Okay. So it was almost universally senior, but there were a few residents, kind of senior residents, fellows that we interviewed within the physician group. But we didn't differentiate junior doctors from senior. So most of it was senior.
Any more questions, please? Yes, somebody at the back, yes?
Simon Varley, Manchester Royal Infirmary. Do you think your comments about incentivising clinicians and other groups like the nursing staff are generalisable worldwide? When I visited Boston several years ago and went to a presentation by their CEO, and I was amazed at the difference in the salary bases across the organisation compared with the rest of Western Europe, for example. So where you're starting from is probably influential in how effective it is to incentivise people on top of that.
I was quite surprised because I spent quite a bit of time at Mass General, and I believe that physicians are very well paid, and I think they would agree with that fact. Yet it was interesting to look at human behaviour, because for small, if you're on a salary of $400,000, you would think that $200 is not going to make a big difference to the paycheck. But how well they responded to surveys, to washing hands, to completing notes, was dramatically increased when there was an incentive involved. Now, some people would say that's perverse. Those things should be core business. And what they said to me as well was when they put out an email that talked about incentives, that email was opened by about 80% of the staff, compared to another email from the quality and safety team, which might have had a 5 or 6% openage rate, so to speak. So it was interesting about human behaviour, even on a big wage, how that may influence behaviour. Now, I think views would be mixed on that. They believe that Mass General, that's a very effective system for them.
Question back here, yeah.
Yeah, I'll just debate that with Jonny.
I can't see you, Malcolm, but that sounds like you.
My name is Malcolm Daniel. I'm one of the Health Foundation's fellows that got to spend not a weekend but a year at IHI. Incentives are kind of things you've got to be really careful about. With a Scottish accent, if you're talking about simple tasks, you look at Adam Smith saying, pay the nail maker more, he'll make more nails work for you. That's a simple task. Any good study looking at complex tasks, financial incentives tend not to work. They tend to make the work less good. So the question for people in the room is, do you think quality improvement is a simple or a complex task? And if you think it's a complex task, we've got to think very carefully about incentives. Yeah.
I think those are wise words.
Hi.
There was a study just while we talk about it, Malcolm, which you probably read about diabetic care, and they incentivized people to follow 7 steps around looking after diabetic feet and eye exams, and the performance went up dramatically. And then they removed that incentive, and it kind of wandered down to the mean because the next thing was then incentivized, which might have been children's care. And so people's behavior followed that incentive, but then the other behavior went back to the mean. So,
but would you agree, though, that, I mean, in my experience, money is an incentive driver. It is a driver.
Absolutely.
But that one of the things that we're very poor at in healthcare generally is giving recognition to people. And actually, people being recognised for being good. Most of the time we hide it, and it's almost, especially in this country, I think, where it's almost embarrassing to tell people that I won a prize, but we should be celebrating it. And I think that's a big incentive.
And that came through in the compensation, because compensation is not just about money.
Yes.
We tend to think it's just about money, but time, for most physicians, is very important because they are so short of it. And they say, no one compensates me for my time. People think I must do quality in between a surgical case. I can't be effective like that. I can't help patients or surgical patients when I get to work at 7, I'm busy with surgery till 7 p.m. and the organisation expects me to run a big collaborative on surgical outcomes. Yeah. It's just not going to happen.
No. Question at the back? Yeah.
I find that culture has a lot to play because the work ethic in the cultural background plays a lot, even in the healthcare concept, as far as how people understand work, what the expectation is from them within their work, and what they're expected to produce, and what the incentive should be, whether they should really take it on and do it from the heart, or whether they should be expected or they do expect to be paid for every little thing that they do. And I think even within a culture, depending on the variation, for the first 40 odd years of my life, I lived in the US, worked in the US, and a little bit before that Jamaica, and then the last 5 years Ireland. And I see the difference that culture makes in the way people understand work and their responsibility towards their work.
Yes, so just in response to that, I just reflected the time at the Mayo Clinic. Mayo Clinic now has their own medical school, and tuition is free for people that fit the right kind of compact of people that want to work at Mayo Clinic. So they make a big investment up front. Mayo Clinic pay each speciality the exact same amount. There's absolutely no incentive for volume. And it's funny how now with the new rules around Medicare and Obamacare, how the rest of the US is actually coming around to that. Because the US has largely been incentivized on volume and not necessarily quality and outcomes. And the Mayo Clinic's an unusual because it's quite a socialist system in a deeply capitalist country. But they've been using those sort of cultural things. For them, culture is everything. It's absolutely everything of the place.
Okay, I'll take one or two last questions. Somebody at the very back, and if you have a question also for John Cullen, it's the sort of final opportunity to put questions to both Johnny and John. Lady at the very back.
Hi, Doreen Lau from Singapore. Just wondering whether you notice any difference in physician engagement if, for example, the CEO and the chief quality officer are also physicians. Does that improve other physician engagement, or you didn't see any difference in performance?
I mean, we didn't measure that specific point, but it came through very strongly about engaged leadership. And most physicians, rightly or wrongly, will respond better to a physician. And that's part of our culture. And you can argue that because it shouldn't necessarily be the case. But it's what most physicians will listen to managers that are physicians as well because of the so-called street credibility. Yeah. They've been in ICU at 2 a.m. with a sick patient, or they've been in the ER when it's been 150 admissions in the morning, or they've done ward rounds till 7 p.m. So that they're able to walk the walk. There seems to be an inherent mistrust of the MBA person who's now the COO or the CEO. So my personal opinion, and this isn't necessarily studied, I don't think, is that leaders that are physicians often are able to lead to engagement. A number of the hospitals I went to, in their constitution, the CEO has to be a physician. And Mayo Clinic's one of those examples, as is Cleveland Clinic. Now in Australia, that would go down like a lead balloon. That would absolutely not be culturally acceptable in my country. Yeah. But in the States, it's very clear within some of those hospitals, the Constitution says that it has to be a physician, which I think is interesting.
I'll show you what the secret. When I was appointed to the Department of Health in Northern Ireland as Director of Safety and Quality and Standards, and my first speech was to the British Medical Association in Northern Ireland, and they were thrilled to know there was a doctor now in charge of quality and safety. A bit less thrilled a few months later when they discovered I had a PhD in psychology. But actually, I can relate to that. People actually thought I was a medical doctor, and therefore they would listen. John, you wanted to make a comment there, I think, did you?
I just... I've broken this now.
Yeah, you can use the microphone here.
So just from the Waitemata District Health Board, we are fortunate to have a doctor who is chairman of the board and a doctor who is CEO. And I think that has made a tremendous difference to the communication, or the ability to communicate between the management side and the clinical side. So we've been very fortunate for that.
Thank you. Ladies and gentlemen, lunch is fast approaching, so in order to help you get to the top of the queue, but before we go, could I ask you please to thank Mark and Sarah handling the sound, Tim on the sound, and most particularly John Cullen and Jonny Taitz for two great presentations.